Hello everyone, welcome to my channel 10 Minutes Medical Rote Learning School. Today's topic is tetralogy of Fallot. It is the most common congenital cyanotic heart disease which presents beyond infancy. It comes under the ventricular septal defect plus pulmonary stenosis physiology. As the name suggests, tetralogy has four components: right ventricular hypertrophy, large VSD, aortic overriding, and pulmonary stenosis. The variants of tetralogy of Fallot includes TOF with branch PA stenosis and TOF with absent pulmonary valve. Absent pulmonary valve has aneurysmal branch PAs which leads to airway compression, hence it presents as a respiratory disease rather than a cyanotic one. The main component which leads to tetralogy of Fallot is the anterior deviation of the coronal septum. This anterior deviation of the coronal septum causes pulmonary stenosis which leads to right ventricular hypertrophy. This right ventricular hypertrophy causes increase in the right ventricular pressures, and when the right ventricular pressures equal to the systemic pressures, there will be no flow via the ventricular septal defect and it will be known as the silent shunt. When the right ventricular pressure exceeds the left ventricular pressure, that is, they become suprasystemic, then the shunting across the VSD will be from right to left. The murmur in TOF is often ejection systolic murmur secondary to the pulmonary stenosis. VSD murmur is not heard as it is a large VSD. The more will be the pulmonary stenosis, there will be less flow across the pulmonary valve and there will be increased right to left shunting and less will be the ejection systolic murmur. The severity of cyanosis will be directly proportional to the severity of pulmonary stenosis, and the severity of pulmonary stenosis will be inversely proportional to the severity of murmur. That is, the severe the PS, softer will be the murmur. Also, heart failure is rare in TOF. If seen, it may be due to anemia or infective endocarditis or right ventricular dysfunction or aortic or tricuspid regurgitation. On auscultation, there is often single S2 and P2 is soft or inaudible. Aorta being quite anterior due to overriding also contributes to S2 being single. The ejection systolic murmur will be due to the pulmonary stenosis and there will be no VSD murmur. Aorta being large in TOF can lead to aortic ejection click being heard on auscultation. On JVP, we will see a large A if there is right ventricular dysfunction. Clinical features of TOF include cyanosis and cyanotic spell. This is seen in children. Older children will present with dyspnea on exertion and easy fatigability. Patients often tire on exertion in TOF because pulmonary stenosis causes only a less amount of blood passing through the pulmonary valve, so it will lead to low cardiac output, and when the patient exerts, it will further worsen the low cardiac output. And often patients will squat to increase the afterload and increase the left to right shunting. These spells are seen often on waking up on an exertion. When the child cries, he becomes dyspneic as there is more decrease in the cardiac output, and this can also often lead to loss of consciousness. In ECG, there will be right axis deviation, right ventricular hypertrophy. In severe RVI, T waves may be inverted in the right precordial leads, often known as the strain pattern. V1 will have pure R waves, but quite characteristic of TOF is the early R2S transition seen in the V2. Usually it's seen in V3, V4, but here in TOF it occurs in V2. Chest X-ray, we see the characteristic core and sabo appearance, that is the boot-shaped heart due to the upturned apex, which is predominantly the right ventricular type of apex. In TOF, there is no cardiomegaly and there is also decreased pulmonary blood flow known as the oligemia. Arch in TOF in 1/3 of the patients is right-sided, which is identified by the indentation on the right side of trachea on PA view. Diagnosis is by echo. Cardiac cath is only required in older children if there is limited echo windows or if you are doubtful, and often to see for the coronary anatomy. The complications seen in TOF are stroke, brain abscess. Stroke can often occur secondary to anoxia or anemia. Anemia is a very bad reason and has to be corrected in TOF, as in anemia there will be decreased RBC deformability. Also, the viscous circulation may also contribute to the occurrence of stroke in TOF. The diagnosis of TOF often is the indication for surgery. And if there is spell, first you have to manage the spell. Prophylactically, oral beta blockers are started to prevent the spells along with the iron. Treatment is surgery where we do the VSD closure, we do infundibular dissection, and also if required pulmonary valvotomy or transannular patch. Transannular patch can lead to pulmonary regurgitation later on. If branch PAs are not adequate, or if the child is sick, spelling very badly, having very severe cyanotic spells, then palliative management in the form of Ballock-Taussig shunt may be required. Ballock-Taussig shunt is done from the subclavian artery to the RPM. Post-surgical also you have to follow up because complications are seen, like RV will dilate, PR can occur as discussed due to transannular patch, and also arrhythmias can occur more often if the ventriculotomy has been done. So I hope you liked the lecture. Thank you. Till next time. Bye bye.